On June 9th, 2022, the Canadian entrepreneurs in New England hosted Accelerate, Technology and Innovation. In this company showcase, Chief Executive Officer Ashwin Kutty led a presentation on WeUsThem to a panel of industry experts.
I'm not going to be ignoring you guys, but you're just in the wrong spot there. WeUsThem. My name is Ashwin Kutty. I'm the president and CEO. We recently put together a health IP that we that's specifically geared towards mental health and addictions. It's targeted towards adolescents and youth initially, and it's primarily geared towards dealing with the problem that we have, especially in Canada, where we have a 6 months to a 1 year wait for individuals to actually get a clinician or a care provider. And so we deal with the problem. So we have telepsychiatry, for example, dealing with the problem of, when we had COVID and the pandemic and kind of meeting with the care providers. So that was certainly there. But what we haven't dealt with is the fact that we still have a bottleneck of the number of care providers that we have in the system. And we still have a growth in demand as far as kind of, counseling services and psychiatry services that people require. And so that's still not dealt with. And what happens within the 6 months to a 1 year period while they wait is that the individuals deteriorate. There's tons of research to state that people are just sitting on the wait list and they're deteriorating over time. And every government has taken a different approach in terms of how they deal with those wait lists and kind of bringing them in faster and sooner and quicker. And so what happens during those wait list periods is that individuals end up getting either of two things. One, they get group therapy, which is not individualized. So you end up sitting in the group and getting very generic group therapy. This is even pre-triage. Or second, they get generic resources that they're told that they should read and they should kind of consume, and then they should do whatever they want with it in terms of how they self-manage themselves. So that's where we come in. So what we did was we took Dr. Sam Kuchar's, Senator Kuchar now, his research and his clinical tools that is now being used in about 40 countries, and we've actually put it into an app. And we've taken all his clinical decision-making tools, and that IP has been transferred over to us for those tools, along with medication management tools, journaling tools, activities, exercises, reminder notifications, care plans, all of those pieces, and put it into a singular tool that the individual can now self-manage their own care while they wait in that waiting period. And our approach has been is that, so this way individuals get individualized care. So they take an assessment, they get told exactly where they sit within the spectrum of the illness and what they're supposed to be doing at that given point in time. And this is not meant to kind of create liability in any fashion, because it's still pushed as a self-management tool. So our clients technically are healthcare institutions, academic institutions, insurance providers, and corporate institutions, because our product goes for both youth and adults, and the only difference between the two is just the branding and the visualization of the app. And so that's pretty much the solution. I think where we're unique is that it follows the individual all the way through their care journey. So it's not just at the waitlist period, but now that you see the clinical care provider, you can have the app integrated into any EHR, EMR that is HL7 or FHIR compliant, which are the compliance standards for some of the tech that's in healthcare. And so once that's integrated, what happens really is you go and meet your care provider, and the care provider says, this is your care plan for the next month or so, before I see you again. And so they'll probably give you new medications, they'll probably tell you to do a few exercises, and then they'll also probably tell you to do and do a few activities and what have you regularly on a daily basis, journaling and what have you. All of those pieces come into the app and it gets distributed into different components. And so the medication management tool kicks in and says, I filled out your prescription, and it keeps reminding you until you fill out the prescription. Once you do, it reminds you in regular intervals as to when you're supposed to take those meds as well. The same goes for exercises and activities, the same goes for journaling as well. And so the tool basically works with you to make sure that you have all of those components taken care of until you meet the care provider again. One key aspect of the tool also is that with all the assessments that we've built into it, it also has suicide ideation built into it. So if you actually come to a point of self-harm or suicide in some fashion, it's tied to 911 and the suicide prevention hotline, but in Canada it's tied to the kids' health phone. So if you want to reach out and kind of reach for assistance or help, you can certainly do that right from the device itself, right from the app itself, and get that assistance right away. And at the same time, triggers are sent to the care provider so that they know that something's happened and they need to kind of reach out and kind of deal with the problem as it is. Long story short, right now, We are commercializing the app in Nova Scotia, and we've got two more in Ontario that we're going to do in Q3 of this year. We've just been to Atlanta with NSBI, and there's been some interest from Hillside on the community services side, and so we've been talking to them about that. And there has been two trials that we've already begun negotiations with in Mexico, and a partnership with Headspace in Australia. And so we'll be doing that hopefully in Q3 and Q4 of this year. The one cool factor that has just recently come out with our work is that we have had a phenomenal interest from the First Nations and Indigenous populations in Canada. And so we're partnering up with Ulnaweg, which is a business development arm of our First Nations and Indigenous communities on the east coast of Canada. And what they are planning to do is bring this app into kind of the rural communities and the First Nations and Indigenous communities. And if, depending on the trials and how it works out, we plan to roll it out across the country, and also in New Zealand where they have tie-ups as well. The last piece that I will leave you with also is that recently, just before we came here, we have one of our largest grocery chains in Canada, Sobeys, that's across the country, starting to get their toes into community healthcare. And so they have just recently partnered up with the province of Nova Scotia, that's on the East Coast, to deliver community care on the East Coast. And through our partnership with the Health Authority in Nova Scotia, we're starting negotiations with them on rolling this out kind of in their community care model, because they have found it to be very profitable for them to get into the healthcare business, and they're planning to kind of roll this out across the country. And one of the coolest aspects of that is that our app, when it was first trialed in Ontario, was tied into the Microsoft Health Vault, which TELUS Health was using at the time, and they are their direct partners as well. So we're right into the ecosystem as well. So we're looking to do that as well. With that, I will stop and take questions.
Right, questions and then comments.
Curious from a regulatory perspective, in the U.S. at least, is this telemedicine? Is there going to be any government payer aspect to this, or is it all private party pay? Or?
Yeah, so technically we are selling to the institutions themselves. Okay. And so the institutions themselves are kind of pushing this down to their patient populations. We have found that on the insurance side, you've got Cigna, you've got the Blue Cross folks already providing solutions like this for free during the pandemic to their insured. And some of the healthcare institutions are providing this kind of as a stopgap before they get their patients in as well. From a purely regulatory standpoint, in terms of any liability that may exist for having this kind of work done kind of pre-care, there are basically notifications sent, and there is terms of use and all of that built into it, so that, and it can be customized, of course, per institution and per state and what have you, per jurisdiction, so that it basically identifies itself as a self-help, self-management tool. So you are basically taking control of your own health until you get to the point of actually the care process itself. So once you get into care, there's no difference in liability as you would have it if you were coming into the clinical setting. So it would be exactly the same. It's just be expanded into the remote model.
One question on I'm assuming this is for profit, right?
Yes.
So how do you define your value proposition when you go and talk to these institutions and your client?
So we've our business model is based off of the fact that as your patients deteriorate, you're spending a lot more money, because now you're dealing with a lot more complex case at the end of the whole wait period. So what we're saying is you're dealing with them early on. And so in Canada, what we have, one of the biggest ones that we have is we spend somewhere north of I think the last time we checked, $61 billion on an annual basis on inpatient care for mental health, and this is because people just keep deteriorating over time, and we keep seeing them on the inpatient side as opposed to seeing them in the community or the outpatient side. Our solution says is that deal with the patients in the outpatient, keep them in the community, take care of them there, and you won't actually have those burdens of cost come into the system as far as the healthcare system is concerned. Academia, the solution is simple, because we were I'm not going to say the name of the university, but we were at a university in Ontario, and they're one of our largest 15 research institutions in Canada, and they have a counseling service that they deliver to their students. And one of the things that they've told us is that we have such a high demand for service provision for our student population, but what we don't have is counselors, and we're not in a place to grow our counseling service to that extent where we can actually service all the students. So for them, this is an easier solution to kind of invest in, because at kind of our rates of cost, for them it's much smaller than they would have kind of building out an entire counseling service as well.
So there are many of these.
Yes, of course.
And they're only as good as the evidence backing them.
Yes.
And you mentioned that you had somebody's methodology that you
Yes.
adopted.
Yeah, so it's Dr. Kucher's tools, and we also have Dr. Bagnall, who's the chief of psychiatry at IWK, and at Dalhousie, who's also our clinical ambassador.
Okay.
And all of this is evidence-based, all of the research for all the tools and assessments and everything that's built
So
into it.
is that how you're differentiating yourself versus all the other?
That's correct. So we aren't the comms of the world, although they have raised a ton of money, of course, for themselves, but we are basically the medical equivalent of what you would get in a clinical setting, because all our tools are being used in 40 plus countries, and they are currently being used in the clinical setting.
I understand that distinction of self-help
Yes.
and self-managed, but I think you've got to look at the regulatory, because the FDA has really evolved in how they think of these digital, in a way it's a therapeutic, it's a digital therapeutic,
Yeah.
right? Because you call it pre-care,
Yes.
care is therapeutic, so this really is therapeutic, so
Yeah.
you probably want to look carefully at what the FDA, how the FDA would think about you.
Absolutely. I think, we had the same discussion when we were looking at the NHS in the UK as an example. And the NHS has this whole policy where they have mobile apps and they want to kind of onboard these into their kind of ecosystem, that they have this entire review process. And they started this kind of as a really innovative thing about 4 or 5 years ago. And we were talking about that, and then I have a good friend who is one of the CIOs in the NHS. And what they've said is basically all of that just basically backlogged with so many apps being submitted that they just stopped the entire process. Health Canada, for example, is now looking at mobile apps and they're trying to figure out how exactly do you kind of go through this vetting process. That's no different than the FDA, who are also doing the same sort of thing. I think they're working together on that. But yeah, it's a great point.
Really important to look at. And
Absolutely.
there's obviously a key distinction between, I think what you're talking about and medication actually being prescribed through the app. I mean, that's something that the FDA is laser focused on right now. There's been some things on the news about overprescribing ADHD medication and things like that in a similar context, but I don't think that's what you're talking about.
No, so medication, so it will be done at the clinical setting and it'll just be downloaded into the app. So it's basically like,
It's supplemental.
yeah, exactly. So it's like taking your paperwork home as opposed to taking the paperwork home, you now have it digitally instead.
And I think the other thing you have to worry about is all the sensitive data, patient data that you're collecting, I'm assuming,
Absolutely.
and kind of safeguarding.
Yes, absolutely. Great. Thank you, folks. Thank you, everybody.
You notice me well.
Thanks to the Consulate General of Canada, Nova Scotia Business Inc., and Foley and Lardner for sponsoring the program. For more information about the CENE and future programs, please visit thecene.org.